You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 14th, 2023. This week, let's talk carotid stents, increased death story with Paclitaxel, Inclisiran, DOAC failures, and the issue of primary versus secondary prevention. Okay, so first topic is that CMS published this week a proposed decision memo regarding the coverage of carotid artery stenting. This is a big deal for interventional doctors, vascular surgeons, and even primary care doctors who may be doing carotid screening, vascular screening. Carotid artery stenting has now been covered in this proposed memo for patients who have symptomatic disease greater than 50% and for patients with asymptomatic disease greater than 70% lesions. Now, they did have specific requirements for imaging and a shared decision-making stipulation. This memo is important because it, expands coverage of carotid artery stenting to those who have previously been available only in trials, and to those patients who have a standard surgical risk, not necessarily a high surgical risk. It removes facility standard requirements and it adds this formal shared decision-making requirement. 4 factors make the carotid artery stenting versus carotid endarterectomy issue a hot potato, especially in the realm of asymptomatic disease. And one is the increase in diagnosis, especially of asymptomatic disease, because we're doing more screening, mostly with ultrasound. Another factor that makes this important is the competition between vascular surgeons and cardiologists for who should be doing these interventions. And the final controversy is whether any intervention should be done in the modern era that has excellent, optimal medical therapy. And finally, and most provocatively, this runs counter to my usual modus, is that despite tons of trial-level data, the decision of whether to intervene and how to intervene in carotid disease requires a ton of content expertise from expert clinicians. This isn't one of those scenarios where a non-content person can just look at trials and tell you what to do, and I'll explain why that is. So Google, ChatGPT, decision aids, algorithms, they're not going to work in making this decision. It's not like getting an ICD or not. Now, before talking more, let's just do a brief review of trials. This will be mostly for asymptomatic disease because symptomatic disease, it's pretty clear that intervention is beneficial. So there were these old trials before the era of high-dose statins, and they established that carotid endarterectomy improved outcomes over optimal medical therapy as long as carotid endarterectomy was done high in quality with a low stroke rate. The criticism of these trials has been that optimal medical therapy has changed and gotten so much better. And since optimal medical therapy can lower the event rate so much that even a low rate of procedural events, you still favor medical therapy over interventions. And some countries do a lot of asymptomatic interventions in carotid disease, like us at the US. Some countries do no asymptomatic interventions, and it's hard to tell if there's really a difference in outcomes. Now, that's carotid endarterectomy versus medical therapy. Now we have carotid stenting, and we have some recent trials. We have SPACE trial, and we have ACS2. Now, SPACE trial. Early on, OMT has a clear advantage. The 30-day rate of any death or any stroke was 2% for carotid endarterectomy, 2.5% for carotid artery stenting, but there were no strokes or deaths that occurred in the first 30 days after randomization in patients randomized to optimal medical therapy. Of course there wasn't. There were no peri-procedural stroke rates when you don't do a procedure. At 5 years in SPACE, there was no significant difference among the three arms for the primary outcome. That's the cumulative incidence of any stroke or death from any cause within 30 days or any ipsilateral ischemic stroke within 5 years. So the numbers are very similar, 2.5% for surgery, 4.4% for stents, 3.1% for medical therapy, but no advantage to intervention in the SPACE trial. In ACS2, this was carotid artery stenting versus carotid endarterectomy. There wasn't a medical therapy arm in this. They had 3,600 patients with asymptomatic severe disease. Now, almost all, about 97% of patients had greater than 70% carotid, and the standard surgical risk patients were randomized to a stent or surgery. And ACST2 also included a meta-analysis of previous trials. This was published in The Lancet, and I'll link to it. Now, this study showed that the 30-day, 1-month risk for stroke or death was 3.8% after stent, 2.7% after surgery, and the risk for disabling stroke or death was 1% after stent, 0.9% after surgery, which was not significant, and also similar to real-world data. Carotid endarterectomy, in turn, had a greater number of MIs, just 0.7 versus 0.3, which was not statistically significant, but there were more cranial nerve palsies, 5.4% versus 0, and that was statistically significant. Now, what are the late outcomes in ACST2? The 5-year risk for any procedural stroke or death was 8.6% after stents, 7% after endarterectomy. These numbers are similar too, but surprisingly, they're not much better than ACST1, which recruited patients in 1993 to 2003. I'll quote the authors. They say, quote, "The main finding from this trial is that the effects of the two procedures on disabling or fatal events are approximately equal in terms of procedural hazards, about 1% for each treatment, in line with findings from large registries. And the 5-year disabling stroke rates, which were about 0.5% per year with either procedure, suggest that they would be about 1% per year with neither procedure." Now, the one caveat I see in the ACST2 trial comes from the supplement. Always look at the supplement. This is Web Figure 4C. This figure shows any stroke or death over the years, and it includes the procedure. It was 5.5% with this carotid stent versus 3.6% with carotid endarterectomy, and I'm drawn to such a graph because patients cannot exclude the time around the procedure. Okay, now, there are ongoing trials and some that have given preliminary reports. Let's talk about ECST2. This is the second urocarotid surgery trial, randomizing 2,000 patients with asymptomatic disease or symptomatic disease and an estimated 5-year stroke risk of less than 20% to two groups: carotid revascularization with either stents or endarterectomy to medical therapy. This is a good trial. Primary outcome is the combined 2-year rate of any stroke, new cerebral infarct on MRI, or peri-procedural death. This May, at a European stroke meeting, we got the results. Through 2 years, the rate of composite peri-procedural death, stroke, or MI was 10.3% with medical therapy alone and 10.0% with a combination of medical therapy and carotid revascularization. That was a big old non-significant difference, hazard 0.96. I'm not sure if this was published, but it is presented, so this is very, very big news. Modern therapy, contemporary therapy, no difference in medical therapy versus intervention with either surgery or stenting. Now, the SPACE2 trial, which I'll link to, this was just asymptomatic disease. It was terminated prematurely due to low enrollment, but the 1-year rate of any stroke or death from any cause within 30 days, plus an ipsilateral stroke within 1 year, did not significantly differ between groups. Surgery 2.5, stents 3.0, medical therapy 0.9%. That p-value wasn't significant because of small numbers, but you can see lower event rates. And finally, the trial that we're all waiting for is CREST-2. This is the big one. Carotid endarterectomy versus medical therapy, and carotid artery stenting versus medical therapy in about 2,500 patients with asymptomatic disease. Primary endpoint, stroke or death at 44 days, and ipsilateral stroke at 4 years. It's estimated to be completed in 2026. So, just a few brief comments and then I'll move on. To me, it sure looks like there is little advantage to any intervention in asymptomatic disease. The old trials showed a benefit, but they had really weak medical therapy. The new trials with stronger medical therapy in asymptomatic disease, boy, it's hard to show a difference. And, when intervening, carotid stenting looks similar to carotid endarterectomy, though I do worry about the higher stroke rates initially. But here is the huge problem, though. I had a conversation with one of our vascular surgeons. Now, he says that nearly all of his carotid artery stenting procedures are now done with something called TCAR, transcarotid revascularization, which involves directly cutting down on the carotid in the neck using a brain protection device via clamping of the proximal carotid and reversal of cerebral artery flow, and then direct placement of the stent. TCAR, in other words, improves the stenting procedure, at least theoretically, because we don't have RCT level data with this new iteration. But you see the problem, right? All of the carotid stenting data involves transfemoral stenting, which involves the issue of traversing the arch, and it's a different procedure. So now you have this massive external validity issue wherein you're trying to apply the data from trials to patients with these new iterations where interventionalists are using a new type of procedure. All right, CMS also calls for a shared decision-making session, which sounds great on paper. I'm all for shared decision-making and being a good doctor, but I have grown quite pessimistic about shared decision-making. I'm super pessimistic when it's mandated. This is because shared decision-making just depends on the doctor and what the doctor wants to do. It's a imbalance of power, asymmetry of power in the doctor-patient relationship. I mean, a cardiologist can cite ACS2 trial and the meta-analysis and say, let's do a stent. You don't want to have surgery, do you? And of course, cardiologists control most of the patients, and then shared decision-making becomes a checkbox in H&P said, yes, I did share decision-making. In a perfect world where medicine was done properly, there would be a true heart team approach to carotid interventions. You'd have an interventionalist, you'd have a vascular surgeon, you'd have an advocate for medical therapy, and you would meet and you would discuss the patient, and the patient might even be there, and there would be no financial incentives to do more cases of one type or another. So EST2, SPACE 2 suggests to me that optimal medical therapy looks quite good. I'm placing my bets on CREST-2 confirming that medical therapy is as good an intervention in asymptomatic disease, just like it showed in the COURAGE trials and ischemia trials. The best approach in patients with asymptomatic disease is probably going to be treated aggressively with medical therapy. All right, next topic, Paclitaxel. Another peripheral artery disease issue was the closure of the mystery of this Paclitaxel-coated devices and higher death rate issue that came up in 2019. That 2019, FDA warned doctors about a, quote, potentially concerning signal of excess mortality that was linked to Paclitaxel-coated balloons and stents, and this concern stemmed from this 2018 meta-analysis published in the Journal of the American Heart Association, and they found a 68% higher mortality at 2 years and a 93% higher mortality at 5 years when Paclitaxel was used in PAD interventions. Now, this led to an FDA advisory committee to recommend device labeling changes, and it really had a substantial effect on peripheral interventions. It even paused some of the ongoing trials. Now, recently, boom, FDA has reversed course and said, no worries, all is well. They've looked at more data. They cite at least 4 newer studies that show no increased risk with paclitaxel interventions. But the thing that I never understood with this issue was what was the mechanism? How could so little paclitaxel, the amount in a balloon or stent, affect death in a patient with peripheral artery disease who has so many other competing causes of death? Now, most of the FDA data that I reviewed that's listed on their website is observational. They said they will keep monitoring, but I guess we are back to normal. Now, if any listeners have a good explanation as to why this signal emerged in the original meta-analysis, could it have all been just noise? Just let me know. I presume for now that it was statistical noise. All right, third topic is the drug Inclisiran. It has got a new FDA upgrade. FDA recently approved a broader labeling indication for the injectable LDL cholesterol-lowering small interfering RNA agent called Inclisiran. Inclisiran has a unique mechanism of action. It works by silencing RNA involved in the synthesis of PCSK9 molecules. The protein helps regulate the number of LDL cell surface receptors, and it's twice yearly injection. Yes, twice yearly. The drug was already approved in 2021 as an add-on for statins in patients with clinical cardiovascular disease or familial hypercholesterolemia. The new indications now include patients taking statins for primary hyperlipidemia who also have high-risk comorbidities such as diabetes, but who do not have a history of cardiovascular events. Well, I think this was based on a subgroup analysis of Orion 11 trial published in the European Heart Journal in December 2022. This included only primary prevention cohort from the original Orion 11 trial. I'll link to that paper in European Heart. In this primary prevention cohort, Inclisiran significantly reduced mean placebo-adjusted LDL cholesterol levels by a whopping 44% from baseline to day 510. Now, as for safety, there were no big differences, but the editorialist of this paper did note, for instance, the proportion of new, worsening, or recurrent malignancy was 5.1% in the Inclisiran group versus 1.9% in the placebo group. Now, several previous trials with these lipid-lowering therapies have not shown an increase of malignancy, but the editorialists call for robust post-marketing surveillance, which, of course, sounds reasonable, right? Even small signals in these randomized controlled trials are going to be difficult to find. Now, my comments. The big thing with Inclisiran is that while there are major reductions in LDL cholesterol and a novel mechanism and twice-yearly injections, we have very little clinical data. We do know that compliance is going to be higher with this drug because of the easy twice-yearly injection. Now, for Inclisiran, the Orion 4 trial is currently evaluating the efficacy and safety of the drug on major adverse cardiovascular events among 15,000 participants who have pre-existing atherosclerotic disease, and the results are expected in 2026. So a couple of years from now, we'll know whether this drug reduces cardiovascular events. I find it a bit strange that such a drug is unleashed on the market without efficacy data for clinical outcomes in a specific trial. Now, we do have a meta-analysis published in European Heart Journal in January. First author, Dr. Ray, were in the pooled Orion 9, 10, 11 trials, and they found that Inclisiran did significantly reduce a composite MACE, hazard ratio 0.74, which was statistically significant, but they did note that there was not fatal or non-fatal MI reduction significantly, nor was there reduction in non-fatal or fatal stroke. Now, with this degree of reduction of LDL, you'd expect that MACE outcomes would be decreased, especially in secondary prevention, but there are still a lot of unknowns with this drug. I also wonder, I can't help wondering this, if the clinical outcomes trial might have come faster if the company knew it was required before approval, like, say, new diabetes drugs have to pass muster in cardiovascular outcome trials first. All right, next topic, a quick one, but an interesting one. What to do with strokes that happen on DOACs? This week, a colleague in the hospital, doctor's lounge, came up to me and asked if I had seen this interesting paper on what to do when a patient has a stroke whilst taking a DOAC. No, I said. Well, it was from the journal Neurology, which I don't keep track of the table of contents there. But this paper was a decent effort to deal with this really super perplexing problem of what to do when a patient taking a DOAC comes in with a stroke. Now, the first step, obviously, is to take a good history and to be sure the patient was actually taking the drug appropriately. I've seen many patients who have a stroke on DOAC who admit to once daily dosing of apixaban because of cost, or skipping days due to cost, or say a drug interruption for a test, even a screening colonoscopy, gulp. Yet, still, just as there were in the clinical trials of DOAC versus warfarin, there was a finite rate of stroke in the DOAC group. So a group of researchers in Hong Kong, in the journal Neurology, looked at about 2,300 patients who had non-valvular AFib and had had a stroke on DOAC. And then clinicians decided what to do. So they had groups, and they used propensity matching to match these groups. They were non-random comparisons, and they had three groups: a patient who remained on the DOAC, a patient who switched to a different DOAC, and those who were switched to warfarin. And their primary outcome was recurrent stroke, and the results of this paper were clear. The control arm were those who remained on DOAC remainers. Those who were switched to warfarin had a nearly 2x risk of future stroke. Those who were switched to a different DOAC had a 62% increase. Both were statistically significant. Interesting was that in the DOAC same group, adding an antiplatelet was not associated with less recurrent stroke rates. And they also looked at risk factors for having a stroke while taking a DOAC, and these were diabetes or the presence of a cytochrome P450 or PGP modulator, and also the presence of large artery atherosclerosis. So my comments here: I want to be careful because you know how I feel. This is a non-random comparison, and there is always the risk of selection bias, namely that a doctor decided what to do, and patients who remained on their DOAC might have been healthier, and that is why they had lower stroke rates. But these are interesting observations, and it's something that we see often. I mean, people want to call such events an apixaban or rivaroxaban failure. And if the drug failed, then obviously you need to do something different. I've even thought that too. It's normal human nature. But when this happens, I think you need to fight that urge and think deeper, think harder. I mean, DOACs don't provide 100% protection. They reduce the risk. Now, what I do in this situation is I go look at the MRI with a neuroradiologist. If the recurrent stroke is a lacunar infarct, we might consider an antiplatelet or boosting the statin dose. And if there's a carotid lesion, you'd send the patient to vascular surgery. But if this is simply a recurrent stroke from AF, an embolic stroke, the best choice might be to stay the course. And what I take from this observational study is that this would be a perfect place for an RCT. You randomize staying on a drug, you randomize switching to a different DOAC. You probably don't randomize to warfarin because, boy, that looked a lot worse. All right, last topic, just a few thoughts, not even about a study. Let's just talk about primary versus secondary prevention. Recently, I discussed a bempedoic acid sub-analysis that focused on patients in the CLEAR outcomes trial who were deemed primary prevention candidates. We had a bit of debate on Twitter this week about defining these categories of primary versus secondary intervention. Now, in the past, this was an easy distinction, and now it's more difficult. Secondary prevention, right, used to mean you had disease. You had a previous MI, an ischemic stroke, peripheral artery disease, a stent, bypass, even unstable chest pain in the setting of known coronary disease. This was heart disease. This meant you were treating a person with disease to reduce future events. Now, primary prevention used to mean we were using interventions to prevent one of these diseases from occurring. But modern technology has rendered this distinction more difficult, problematic. Now you can have a CT for a kidney stone, for instance, and they may note coronary calcification. They may even tell you it's in the LAD. You might be able to run a 10K in 45 minutes, have no other risk factors, and some of my colleagues would say, that's it, there it is, you have heart disease. Now, the popularity of doing coronary artery calcium scans has brought this question to the fore. I see few coronary calcium scores that are negative or zero. But does a person with calcium on a coronary calcium scan, maybe it's in the LAD, does that patient have heart disease? Is he or she primary or secondary prevention? And I would argue that A, this is far closer to primary prevention, but B, I don't think it matters that much, right? We know that statin drugs reduce future events by 25% in relative terms. And that is in low risk, medium risk, high risk patients. It's kind of a smooth reduction. You don't exactly know the starting risk, but you can get in the ballpark of what that absolute risk reduction is. And you just discussed this with patients. Some patients love that absolute risk reduction. They want to do everything they can to reduce heart disease. They're maximizers, so to speak. They take that 25% risk reduction and they like it. It's worth taking a pill. Others are like, look at that absolute risk reduction and it's a very small number and it's not worth taking a pill for. It seems to me that technology has rendered the dichotomous primary-secondary prevention category sort of irrelevant. I'd be interested in what you think about this. So that's it for this week in cardiology. As always, I'm grateful that you listened, and I want to say a special thank you to all the feedback that I'm getting. It helps me. I'm learning. Thank you for that. I'm very excited to say that we're up to 650 ratings on Apple Podcasts. That's amazing. And please keep it coming. If you like this podcast, please take the time to give us a rating. Write us a 1 or 2 sentence review. These go a long way to helping others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.